Welcome to our first webinar for building COVID-19 research collaborations. I am Penny Gordon-Larson. I'm a professor of nutrition and the Gillings Associate Dean for Research. And Dr. Alexia Kelly, who is the Senior Director of Research, and I welcome you very much to this webinar. And we're hoping to do more of these COVID-related research webinars in the coming weeks. So please stay tuned. And if you are interested in presenting during one of the webinars, please email Dr. Kelly. For a little logistics, I will be introducing the speakers. I'm going to introduce both first, and then they'll each speak in turn, and then we'll have an open question and answer session from the viewers. We are going to keep you muted, so just use the chat function at the bottom of the Zoom menu and enter your questions, and you can do this throughout the presentation. After the presentation, I'll turn the floor over to Dr. Kelly. She'll moderate the Q&A session, and then she and I will read questions aloud. So the title of the session today is Changing Your Shoes While Riding a Bicycle During a Hurricane. This is developing COVID-19 models on a policy timeline. And I think we all feel the sentiment of this exactly right now with everything we're doing, but particularly for those who are really actively engaged, like Kim and Mark are in the research and policy side. Things are moving particularly crazy, in crazy fashion right now. So it's a challenging time for all of us. And in relation to that theme, I've asked each of them how they were coping. And so to introduce Dr. Kim Powers, she is an associate professor of epidemiology, and she uses epidemiological, statistical, and mathematical models to study infectious disease transmission. She has a strong focus on HIV and sexually transmitted infection transmission prevention, and she's recently expanded her modeling efforts to study SARS-CoV-2 transmission dynamics. So she is personally coping, admittedly poorly, with the COVID onslaught and its accelerated timelines by eating frosting straight from the container and letting her children watch way too much TV. When she's finished with the presentation, she'll turn the floor over to our second speaker, who is Dr. Mark Holmes, professor in the Department of Health Policy and Management. He also directs the Shep Center for Health Services Research. His research interest is health policy, including rural health and payment methods. And his professional goal, and I've seen a couple of these, is to do Zoom call from almost every room in his house. So Kim, take it away.
Okay, thank you, Penny, and I'm very pleased to be here with everyone today to speak about modeling SARS-CoV-2 transmission in North Carolina. And I apologize for the green tint surrounding me. For those of you who can see me, I'm not underwater. I'm not in the Emerald City. It's a funky feature of my laptop webcam that I can't seem to get rid of. So please bear with me. Okay, so modeling the transmission of SARS-CoV-2, which is the virus that causes COVID-19, the disease. I'm going to start with just a very brief primer on some of the fundamentals, the basics of epidemic modeling. And then I'll tell you just a bit about some of the work that I've been doing here in North Carolina to model SARS-CoV-2 transmission in our state. Okay, so starting with our primer and beginning with a definition of what is a mathematical model. So a mathematical model represents a system. In our case, when we're thinking about infection transmission, that system is a population. So a mathematical model represents a system, again, in our case, a population, in a way that allows us to analyze mathematically or simulate that system under a range of different conditions using equations and numbers. So at the most basic level, a mathematical model is a set of equations and numbers that allow us to simulate or analyze a system. As with any model, mathematical models, and in particular epidemic models, are deliberate oversimplifications of the system we're interested in, where we've designed that oversimplified representation to capture the fundamental aspects of the system that are important to allow us to faithfully represent that system and analyze what might happen under different scenarios. So it's as simple as possible, but no simpler. And that can be a trick. There are many uses for mathematical models in infectious disease epidemiology, many uses, and this is not an exhaustive list, but I think some of the big areas where mathematical models are very useful in their application to infectious disease epidemiology is to help us understand disease patterns, understand the spread of transmission, the spread of infection, and the patterns that we're seeing on the ground in terms of infection transmission in a population. Models can be very useful in helping us to quantify the importance of different disease determinants, so different biological cofactors that may be important in driving the spread of an infection, different behaviors, interactions between different behaviors and biological cofactors. What are the drivers of the infection spread in a population? So models can be very useful in helping us to answer those types of questions. Certainly one that we've been seeing a lot of lately with SARS-CoV-2 is trying to predict the future course of an epidemic. That's obviously a hot topic and a question of great public health importance right now that models are being used to address. And then going along with that, models are very useful in general and with the current pandemic in evaluating the potential impact of interventions designed to slow the spread of infection and different combinations under different coverage levels and those sorts of things. Looking just in a little more detail at some of these questions in the current pandemic and the ways that models have been used to address some of these burning questions. I've just plucked a few of the more prominent models that have been coming out lately, just as some examples of the types of questions that we're looking to answer here. So here's one that was published in Science, I think a week or two ago, where the investigators led by Mark Lipsitch at Harvard were projecting the dynamics of SARS-CoV-2 for the foreseeable future. And spoiler alert over here, as you can see, their model and many similar models are predicting that we're going to be dealing with this for quite some time over the next several years. Here's another example that has come out in the last few weeks, also published in Science, led by Christoph Fraser's group at Oxford in the UK. Where they were looking at the potential for digital contact tracing to control the epidemic as a faster means of tracing people who have been potentially exposed to infection and slowing the spread in that way. So that was another nice application of mathematical models to the current pandemic. A couple more examples. Here is one also from Mark Lipsitch's group at Harvard, examining and comparing the impact of, or the potential impact of quarantine versus active monitoring of contacts for mitigating COVID-19. And then final example I have here out of the Imperial College group led by Neil Ferguson. And this is maybe the one that first made a splash in the mainstream media with an article in the New York Times, and certainly lots of buzz around this one, was where they were looking at the impact of non-pharmaceutical interventions, which currently, in the absence of treatments and vaccines, are the only kinds of interventions we have to reduce mortality and healthcare demand in Great Britain and in the US. And just to show you kind of a nice example of the ways that these models can help us to envision what we might see under different scenarios. This is a figure from that modeling exercise out of Imperial to orient you on the y-axis, and I know many of you have probably seen this paper. On the y-axis, we have critical care beds that would be occupied under different scenarios per 100,000 population. The x-axis is time, and then this red line here is critical care bed capacity under surge conditions. So way down here at the bottom is this red line. And what they found was quite alarming with their model, where they predicted the spread of infection under different scenarios. So this is what they predicted with a do nothing scenario. So wildly outstripping capacity, going well above that red line. And then they looked at a couple of different intervention scenarios. The orange scenario represents case isolation, household quarantine, and general social distancing over this blue period of time here with the shading. And what we see, as you might expect, is they flatten the curve, and they do predict going above that red line, but not anywhere near what we see with the black curve where we do nothing. And then, unfortunately, we see a second wave of infection later in the fall. Similarly, they look at school and university closure along with case isolation and general social distancing and show even better control through this period, and then a bigger surge again in the fall. So this is a nice example of what can be done with models. It's a horribly depressing example, but unfortunately is kind of what we're dealing with here. So how do we build these models? How do we make these models? So this is a crash course in epidemic modeling, and there are lots and lots of different types of models that are used to answer these questions. What I'm showing you here is a representation of one of the more basic, more commonly used types of models that we refer to as a deterministic compartmental model. And the way that these models work is we take our population and we divide it into a set of mutually exclusive compartments or states that people can be in at any given point in time. So in this example, what I'm showing you is what we refer to as an SEIR model. You may have also seen SIR models, which we often use to teach these concepts. But basically here, what we do with an SEIR model is we divide the population into 4 different buckets that they can be in at any point in time. So S is for susceptible, so not yet infected. E, which stands for exposed, but really represents being infected but not yet infectious or latently infected. I is infected and infectious, and R is recovered from infection, either recovered or removed from the population through death in this particular example. So in addition to these 4 compartments, we also, we further specify the model by specifying transitions that can bring people from one compartment to another. So people can move from the S box to the E box through the process of infection acquisition at rate lambda. People who are latently infected, so infected and not yet infectious, can become infectious and move to the I box at rate sigma. People who are infected and infectious in this I box can move to the recovered compartment through the process of becoming non-infectious at rate gamma. So that's the general layout for how these models work and how they're structured and laid out. Along with these compartments, we have equations. So these, there's one equation per compartment. So one for S, one for E, one for I, one for R. And what I'm showing you here are differential equations that describe the rate of change in the numbers of people in each compartment as a function of these transition parameters that move people from one compartment to another. And if we can kind of initialize this model, by providing values for the numbers of people in each box to start. So when we're thinking about a newly emerging infection like SARS-CoV-2, we have pretty much everyone in the S box, and then we kind of seed the population with a handful of cases in the infectious boxes, infected boxes. And then we provide estimates for these transition parameters that move people from one compartment to another. What are these rates? And we draw those from the literature, from what we know about an infection. With those values, kind of specifying the model, we can simulate an epidemic with our computers and see what we would expect to happen under different scenarios. So when we run these models, we get numbers of people over time in each compartment, something along these lines. So this is showing you a simulated epidemic. using 1,000 different sets of parameters where we draw the input parameters, those Greek letters, from distributions that we specify on those input parameters, and then we run the model, solve the equations, and simulate what we would expect to see in the population with those input parameters. So that's the general idea about how these models work, and we can look at these curves over time and visualize what we would see, and then also analyze mathematically these numbers and report on those numbers for each of the compartments in the model. So I'm showing you one compartment here, but we have something similar for each of the other compartments. Okay, so that was our crash course in epidemic modeling. Everybody passes. Now we will talk just a bit about modeling SARS-CoV-2 in North Carolina and some of the work that we've been doing here. Okay, so in North Carolina, and really everywhere, some of the big questions that we've been asking that are super crucial to minimizing damage in the current pandemic are questions like, will we exceed hospital capacity? That's a big concern. We've seen examples of places where this infection is so infectious and so damaging that there have been runs on hospital beds and not enough capacity to effectively deal with the need. And of course, that's a concern here in North Carolina as well. A big question is, does physical distancing, or what we commonly hear as social distancing, but I think we're leaning more toward physical distancing as the term here. Does physical distancing help? How much can it help? How much is it helping? Those sorts of things. And then another big thing now, particularly as we're moving toward trying to think about lifting or relaxing some of the current intervention approaches, is what can we expect under different scenarios of reopening, and how can we most safely try to do this? So these are all questions that epidemic models are very well suited to address. So thinking about these questions in North Carolina, what I'm working with now is a model that I and several collaborators have developed to describe the natural history of SARS-CoV-2. And so this is a very similar type of approach to the SEIR model that I showed you. We still have the S, we still have an I, we still have an R. But as we've learned more about SARS-CoV-2, it is looking like there's a portion of the population that is asymptomatic and can potentially contribute to infection, to transmission. And then there's the remaining portion who do go on to develop symptoms, but they have a pre-symptomatic period and a symptomatic period. People who are asymptomatic are, for now, we're sort of ignoring their potential to be diagnosed, since testing is rather limited and seems to be much more focused on symptomatic people. So people are susceptible. Those who are asymptomatic stay as asymptomatic and then ultimately recover in the model at present. Then the other pathway is people are susceptible, they are pre-symptomatic, they become symptomatic, and all of these arrows have Greek letters associated with them, but I didn't busy the slide with those. Become symptomatic, here they are infectious and symptomatic, they can just recover, or they can be diagnosed, and having this diagnosed compartment allows us to try to match our model with what we're seeing on the ground in terms of diagnosed cases. People who are diagnosed can recover without going to the hospital, or they can be hospitalized, and this is a compartment that we try to calibrate to what we're seeing on the ground in terms of hospitalizations. People who are hospitalized can then recover, or they can meet their demise from this horrible infection. So these are the different pathways that people can follow in the model at this point. Again, it's very oversimplified, but is a set of compartments that we can start to reasonably think about as we learn more about this infection, and it includes compartments that allow us to answer some important questions and calibrate to what we're seeing on the ground. So again, each of these arrows has a transition rate and a Greek letter associated with it. Each of these compartments has a differential equation associated with it, similar to what I showed you for the SEIR model. This parameter here, this lambda, is a time varying function that is a function of a beta parameter that describes how people are contacting each other, or how frequently people are contacting each other in the population. So that's something that can change over time with different physical distancing interventions. And so that's a big focus of the modeling efforts. And then this term here represents the numbers of people who are potentially infectious, and they have variable infectiousness depending on whether they're asymptomatic, pre-symptomatic, or symptomatic. So that's the general idea. Again, this beta parameter represents how people contact each other, how frequently people contact each other in a way that could result in transmission. And again, this is something that we expect to change over time with different intervention strategies. And the way we've been thinking about this beta parameter, because we don't have great measurement of exactly how people are contacting each other, is we're using mobility data collected from GIS, GPS data from cell phones. These are publicly available anonymized data that show us patterns of mobility over time. It's kind of a rough proxy for how this beta, this effective transmission rate, might be changing over time. And so what we've seen in looking at these data just statewide, and this is an analysis that was done by my student Rachel Billick, is that for the first couple of weeks of March, people were going about their days in ways that were pretty similar in terms of their distances traveled to what they were doing prior to the beginning of March. So kind of business as usual till about the middle of March. And then you see this pretty sharp decline in people's movements again, this is statewide, aggregated at that level, a pretty sharp decline in how people are going about their business. And what the vertical lines here represent different executive orders. So you can see those superimposed here, but people were really starting to get the message even prior to those, and you can see these declines over time. So we're using these sorts of data to parameterize what that beta, that contact rate is in the model over time, and we can look at different scenarios with different changes. So in one scenario, we can see what happens if there's no change in these rates, or if there are what we see here and what happens going forward, those sorts of kind of hypothetical scenarios. And just to give you a quick example of what we see, or what we can look at, is these are model predicted hospitalization, people in hospital over time in a couple of different scenarios, one where there is no social distancing and one where there is social distancing. Again, these are kind of just illustrative examples. Don't squint too hard at the axis, but just to show you the type of thing we can do is model these different scenarios with different beta parameters describing contacts over time, contact rates over time, to predict different expected realities under different intervention scenarios. So according to the model and what we've seen in terms of movement in the population, we expect that this social distancing or physical distancing is working and will work. So this type of analysis that so far I have contributed to a really nice collaborative effort that has arisen very quickly across many different organizations here in the Triangle, with some really fabulous researchers, a very multidisciplinary team, and Mark will be talking more about that. But we have several different models that have been developed, and we're working together to try to triangulate and synergize efforts to get sort of a multi-angled look at what we might expect in North Carolina. So the model that I just showed you is one of the models that has been contributing to this effort. We had a press release come out a few weeks ago looking at one particular issue, and that was hospital capacity and the COVID-19 epidemic in North Carolina. where we all used our models to try to address this question. Headline findings from that brief, we looked at a couple of different scenarios, one where we maintained a range of aggressive policies to limit transmission beyond the end of the current stay-at-home order, which is set to expire next week. And then in the second scenario, we modeled what would happen if we maintained those policies through the end of the month and then lifted them. And the major takeaway from the analyses that we did across models to answer those questions in those scenarios was that, as you would expect, maintaining social distancing policies for the longer term would give us the best chance of ensuring that we had sufficient healthcare system capacity to manage the numbers of SARS-CoV-2 infections. Whereas in the scenario where we were to lift all those policies soon after the end of the order next week, then we would have a pretty non-trivial probability that our ICU bed capacity would be outstripped. And I think Mark will be talking more about those results and the collaborative effort that we have and translation to policy, but that's just a preview. And I think I'm just about out of time here, but for next steps with this model, what we're going to be looking at is different reopening scenarios with consideration of reopening schools and workplaces and having particular attention to older and other vulnerable populations, thinking about what we might need in terms of testing and contact tracing capacity, and those sorts of questions that are important to our public health officials on the ground. Just sort of quickly in closing, some reflections. I know that the title of this seminar today is something about riding bicycles and changing shoes and being in a hurricane, and I have to attribute that title to Mark, who came up with it, and it's a brilliant analogy to what this time feels like. Some of the modeling that we've been doing has been likened to models for predicting hurricanes. I think with those sorts of models, there are some similarities where we know there's something coming and we know it's probably bad and we don't know exactly where it's going to hit or when, but we're doing our best to try to model that and predict that so we can be prepared. I think that the weather models have had more time to get their input parameters and understand their system really well than we have with the current pandemic. So it's been I think this guy's face sums it up pretty well for what this experience has felt like. Another analogy that I think works quite well here that I've heard and that I've used is that we're building the airplane while we're flying it, which we're building these models while we're using them to predict what's going to happen. We're putting the wings on, maybe we see we need to change some things. We've got our map or our diagrams. This guy looks really calm, which I don't understand, but so I think both of these analogies work quite well. We're predicting the hurricane, we're building the plane to fly around it, we're trying not to run into it, and it's been a whirlwind. I come from an HIV modeling background where we have decades of experience knowing what to expect with transmission dynamics, knowing what our input parameters are, knowing what the impact of interventions might be. So this it's been a really interesting and challenging experience to be in a completely different context where we are building this airplane as we go, and while we've got the tools, it's really the challenge is in having the data to inform the models and have as inputs in the models. And so it's been a whirlwind. It's been a learning experience. It's been amazing to join all sorts of different collaborations, and it's been really I think super inspiring to see everyone come together and work on this and really mobilize to try to limit the impact of this infection. So with that, I guess I'll hand it over to Mark and we'll do questions at the very end.
That's correct.
I will exit. Okay.
All I done this? Can everyone hear me? I think someone will holler if they can't. Okay, so I am picking up where Kim left off, which is did a great job filling a lot in. So I'm going to be talking primarily about the structure process of what we did and how we communicate to policy, how we communicate our findings to policy. Okay. So here's the timeline, as Kim alluded to. You know, this was the direct messaging on Twitter I was exchanging with Aaron on March 17, where he chatted. Aaron McKeithen is sort of our ringleader. He used to be the chief data officer for Secretary Mandy Cohen, and then is now at Duke and a startup company in the Triangle. But we had this exchange late on St. Patrick's Day on March 20th. He organized a call with about 20 researchers. On the 22nd, at the Sunday, we briefed the secretary with the results. We updated the models on the 25th, which was a Wednesday, I think. On Sunday, the 29th, Kim and I went to the Emergency Operations Center and presented to the governor with what our models were saying. We briefed again on the 5th. On the 6th, we held this press and legislative briefing. Issued another brief last week, and our third one is coming out either tomorrow or Monday. So it's been not a typical research timeline, as Kim alluded to. It's been quite aggressive in many respects, and I think that's been a big change in why I think one of the things that's interesting about it. I can go through this a little quickly because Kim covered some of this, but I think from the beginning, the vision was not to build a new model, but really to combine efforts that were happening across the state. You know, EPI models quickly became like belly buttons where everyone has one. And the idea was to combine these multiple models into one. We drew from the spaghetti plot here, and just like every fall, people have strong opinions about the European versus the American models. People have opinions about this, but we wanted to embrace this idea of a variety of modeling approaches and understand what those do explicitly rather than build something from the ground up. We had 3 EPI modeling teams. Kim from EPID and her group, RTI, has an agent-based modeling, and then a third that so far has renamed mostly anonymous, and I think they want to keep it that way. A policy team that sort of combined these models into an official forecast, and then a data team or a red team. And this is sort of how I thought about how we were organized. Each of those 3 models on the left, they delivered CSV output. We had to synthesize it into graphs and combine it as a composite. Then there was this data red team that sort of was, offering questions. Oh, here's a good data source you can look at. Have you thought about it this way? Here's a new development, that kind of thing. As Kim talked about, our primary outcome that we've modeled so far is exactly this surge question. Do we have enough beds, equipment, resources to manage demand at its peak? Acute beds being the primary one, ICUs as well, and then ventilators and to a lesser degree staff has not been something we've gotten into. There are other people who are really working on that, but that's an important component to be thinking about. Other key outcomes, those aren't the only things we need to be thinking about. Mortality, both COVID and non-COVID related. We know about some of this excess mortality that has been found in countries across the world. Foregone care, I sliced my foot really bad 10 days ago. Should have gotten stitches. I think I've managed to field dress it appropriately, and so far my jaw is not locked. But there's going to be other issues associated with that, and certainly we know about the missing heart attack kind of question, mental health and substance use disorder kind of questions. I put that under mortality. It really should have been healthcare use. We also care about infections. That was one of the questions that we cared less about. We were really focused on that primary, but we knew we had to throw that number. I made it in a footnote in the first brief, and that was the headline in most of the media coverage of it. Equity, I think the equity concerns are really pronounced in this particular epidemic, and some of the racial disparities we're seeing in terms of the burden, I think are unbelievably large and need to be considered. And then something that public health tends to think less about, but social and economic disruption. And we've been focusing on sort of those top pieces, but a lot of the drumbeat now is on this social and economic disruption and the idea of the massive unemployment and the income effects associated with that has its own public health burden that needs to be considered. So one of the first questions we had that I had to deal with, whereas the Kim and the EPI people were sort of developing their infection models, very simple question: how many beds do we have? And this is a much more interesting question than it seems like it should be. There's license versus staff questions. How many can we empty for elective versus non-urgent? We know that a number of, joint replacements have been canceled, other elective surgeries have been canceled, but there are other people who are foregoing care, but how much of that is potentially can be changed and pushed aside? Do we have the staff to deliver this care? Can we build field hospitals like we talked about in Charlotte, taking over the convention center, in Durham, taking over Duke University dorm rooms? There are some recently closed rural hospitals. Should we reopen those? How does the capacity change seasonally? You can see on the bottom right here, here's a seasonal graph that shows how occupancy varies throughout the year. And how should we think about regions? We need to think about different ways of organizing the state. We're large enough that we shouldn't think of it as one behemoth. We need to think about different impacts and how the burden may vary across those in terms of the risk factors we've seen. So I have these three pictures here. I like to have these here because this middle findings brief is one the Rural Health Research Group that George Pink led an analysis of to look at developing these occupancy rates nationally as part of their work with HRSA. The top right are county-based modifications of Dartmouth's hospital referral regions. This is work that we did a couple of years ago with Aaron Freyer to build county-based units of that. And then the bottom right is work that came out of Sandra Green and the Department of Health Policy Management and her North Carolina hospital discharge data, where we could look at that. So all three, these three issues became input to answering this question. We've covered a lot of this already. What are the real questions to think about, both the social or physical distancing policy? We really talked about how aggressive it should be rather than the nuance at this point. And then can we surge our way out of this with an equipment increase? What if we had 20% more beds? What if we had 50% more beds? We're assuming then in these models that we could get the equipment and the staffing, which I think are bold assumptions for some of these increases. But at least it was a framework to think about what these models did. So initially we modeled the expected number of hospitalizations and how this compared to available capacity. Think to that one of the charts that Kimberly had with the red line at the bottom that was so low you couldn't see it, and they had the different spikes of how many we would need. But that often, the forecast uncertainty was often highly underappreciated. We have about 20,000 to 21,000 acute beds in North Carolina. Some of our models, depending on the assumption, showed that at our peak, we're at 19,300. Like, okay, we're good. We got 700 extras. We're fine. And we're like, no, uncertainty is way much larger than that. So then we added confidence bands. That really didn't do the trick. So we started modeling the probability directly, drawing from the 538 kind of experience and other election models. Where we don't really care about what the expected number of votes for electoral college is. It's how often do we have a problem in this case, or how often does this candidate win versus the other in election context. So the question that we're really motivated is in what percent of models does the projected demand exceed the available capacity? So as Kim alluded to, there was these three EPI models. Combining them was a major challenge. This was my primary portfolio. Each model varied in their assumptions, how they implemented it, what their output delivered, what was behind those, and some things sometimes as esoteric as, oh, I thought you wanted the number of people who were admitted to the hospital today versus how many we think are in the hospital today. And so that in the first run, we had to fix that and everyone had to go back. This is a consequence of a collaborative like this rather than a project. Basically, this was a coalition of the willing, and everyone was here because they wanted to do good for the state. And if it became too demanding, and there were points as we get close to the brief, it starts to get really tense. we didn't want people to walk away. And so this was, there was a lot of, okay, we can make this work kind of thing. A typical Slack post, and I know I've done this at least 3 times, is I would email or Slack the person who owns the model and say, okay, in order to make your model fit with the other 2 in terms of apples to oranges kind of stuff, here's what I have to do. How squirmy do you get? The reply would be I hate this. And I would say, okay, thanks for the input. I need to do it anyway in order to sort of combine these models. And so there was a lot of suspension of normal practices in order to deliver the outcomes, the evidence we needed. Here's a typical kind of spaghetti plot with the models. I'm including this just to sort of show how they varied and suppress the identities here with them. We called them by state symbols. So there was cardinal, dogwood, plot hound, Scotch bonnet, which next time you're at bar trivia for your North Carolina state symbols, you might win a couple points with that. But this was the general idea. This was a spaghetti plot, looks much simpler than what we had with the hurricane, and then we combine them to form these the black composite line kind of idea. Most of the team had little experience with working on a policy timeline. We had, again, these aggressive milestones. I've done standing 7:30 a.m. stand-ups for the last 3 weeks. Multiple, let's Zoom now, kind of drop everything, jump on a Zoom, and it's okay, here the data are in, here's the status, or here's what we're thinking for next brief, or this is going to work, or did you see what Florida did? We have to adjust how we're thinking about it, that kind of thing. We finished the graphs for the governor brief in the car. Our brief 1 was finally published 3 minutes before we started briefing the legislature. Those are not timelines most of us are comfortable with, but that's the very nature of changing shoes on a bicycle, whatever. We had to change our typical standard of how we thought about this. I like to use the word changing and not lowering because it's a different mission. And we often had to say, okay, normally we would not want to publish this in a peer review setting. We're not 100% confident with it, but the question is, we need to be 80% right today. That's better than being 98% right in 3 months. And in this kind of timeline, decisions will be made by either, what we provide or by what people are reading on Twitter. And I think generally I have more confidence in Kim and people like her than I do in people on Twitter. So it was a big readjustment for thinking through what is the kind of data that we deliver and how do we structure it as standard. And I think this is what it means to serve the state we're in, and when we're at the #1 public school of public health, and all rights reserved with that kind of thing. But I think, I take that seriously. Multiple people on the team did this because they take that mission seriously, and it's just a different way of thinking than what we normally conceptualize. So Kim's alluded to the briefs. The one on the left was a screenshot of the modeling for the probability of exceeding the capacity from the acute beds. The one on the right is one we released on Friday, which is a framework for what we need to think about from reopening. As I mentioned, we have a new one called What Does May Look Like, I think, and that will come out either tomorrow or Monday, which updates the projections for May 1 to May 31 based on the context there. We have a Twitter handle with 20 some followers, but that's where we put out the new briefs as they drop, and then a website there if you're interested in reading more. We've relied heavily on metaphors, and I think that's scientific literacy. It can be a challenge when you're talking to both policymakers and to an even larger extent the public. And we knew we needed to communicate effectively for these really complex issues. We drew from paradigms we think the public understand, hurricanes in particular. We've used the cone of uncertainty. We've talked about spaghetti plots. We've talked about preparing for a Cat 5, and it's either going to hit Wilmington or the Outer Banks, but it's going to hit one, and we need to prep for it. And how do we put up, board up our windows, et cetera, et cetera. And then drawing some, as I mentioned, drawing from elections as well. But we've done a lot of drawing from that because some concepts people are far more familiar with than others. And when you talk about a new virus, we need to draw from things that people are familiar with. In retrospect, I think some of the things we did well. It's a very humble group. I'm delighted to have met Kim virtually. I can't wait to actually see her in person. But we had it's a great culture where we've made it easy from the beginning to ask dumb questions, but we knew when to keep our mouth shut. I really wanted to build an epi model back in early May or March, and I basically had to print this out and put this above my computer. And I think if you don't know what an R0 was before March 1, which I was certainly one, I should not be building an epi model. I had to remind myself of that daily because I think there's this excitement and enthusiasm to do something and to draw from our skill sets we have. But it worked out really well where we let the people who had the expertise do things they were good at, and other people do other stuff. I think other things here that we did well to stand up a multi-organization group. I think we built a workflow process that worked pretty well. Slack was our primary method of communication. I think 80% of people on it had never used it before, but they were able to jump into it pretty quick. We considered other methods, but Slack worked really well. We did a lot of intra-team validation, and I think that when you set it up this way to have people sort of having those 3 teams feed into one, it can be easy to spend all your time red teaming each other's models and not really validate what we've done. We also invested in media prep. When we did the brief on that April 7th or whenever it was, we game planned a lot of questions. We thought about what the day will look like. We invested more in that than I typically do for research stuff, and I think that paid off dividends from that standpoint. The things that we could have done better, I think, I said our workflow worked reasonably well, but to be perfectly honest, I never thought I'd be a Teams fan, but I really missed that. The integration of it, we had to sort of build our own with multiple ideas. We started violating Slack principles. This is a depressing story about the luggage company Away and how they use Slack. We didn't quite go like that, but there were things we could have done better with Slack that we adhered to at the beginning that got sloppy with near the end. We didn't have a common data model, as I talked about, and I'm not usually one that serves as a coordinating center, and so I hadn't thought through enough about that. And one of the big challenges that we've had is the explanation of what I would call endogenous policy. I'm an economist, so I have to use the word endogenous at least once in any time I give a talk. But this idea of our prediction for what will happen in May is a function of what we do today and what we do tomorrow. That's an area where the hurricane parallel does not work well. The example here of Y2K, for 1998, 1999, we heard about how Y2K was going to be a disaster. I held my breath as midnight ticked and said, "Oh, okay, it was all overblown." Well, no, it wasn't overblown. It's that people had done the prep to keep it from being overblown. And I think that's where we are today, as people look out their window and say, we don't have an ICU problem, and people aren't, we don't have beds stacked up in the convention center. So all this was overblown about nothing. And I don't think anyone has really done a good job, found that secret sauce to explain the reason why we're as successful as we are the things we did. We'll probably see some of that in a couple of weeks as states start reopening on different timelines, and that may start breaking through, but that's something that we haven't been able to do well. I know I'm at time, so I'm just going to hit the last cuts, really brief. I've been pleasantly surprised at the politics of this. We got a letter from the North Carolina House Republican Caucus, which I thought was because we were sort of working for the governor and advising the governor, I was worried about that. It was really well done. They were great questions, and they've been really informative. This issue is becoming partisan, as I think everyone on this call has realized. But I think because we've been extremely careful and really adhered to our lane and thinking of the science of this, I think we've been able to largely avoid that and been able to keep it a scientist role rather than a politics partisan kind of role. Keeping the day job has been really hard for me. I mean, as everyone on this team has other things that they have to do, it was easy to set stuff aside for 2 weeks, but now we're at a month and it looks like it'll be a while. That gets more challenging, and that can be tough to sort of navigate. one of the things I realized in the beginning is that I'm like, oh, I don't know about epi modeling. What am I going to do on this? This is a report that I contributed to. I staffed, 13 years ago. Certainly, I knew a lot more about hospital beds than I realized. So I think, this is a place where everyone's got something they can bring, and you just sort of have to figure out if you're really, there's something empowering about contributing and weighing in and trying to move the needle on a issue like this, that there are things that you can bring and just figure out what it is that you have that you can contribute. I think a lot of value of pre-positioned data and relationships, the years of working with collaborators in some cases and not with others, with sponsors, the ability to connect with data owners, people at the state, people in state associations and others that you can work with quickly, get data brought in, spun up. Our ability, we got an NC Detect feed set up really quickly through the state, and that Anna Waller runs, and that has been really helpful. There's skills that we less commonly use in our business: aggressive pace, working with the media, data viz, principles about communicating. But I think largely drawing from Gillings and UNC resources and expertise has been really valuable, because there's a lot that of resources here that I guess was really enabled us to hit the ground sprinting, let alone running. So I think that's all I have, and I know I think we're at less time than we had budgeted, but I think I'll kick it back to Penny and Alexia.
Thank you so much, both Kim and Mark, for all the work that you're doing, and also for sharing your expertise and experiences with us today. And I just want to remind people that if they do have questions, please put them in the chat. So we've had a couple, and Kim, I'm going to unmute you so that you can join in on this. Oh wait, no, I just need, okay, there we go. So the first question was from Catherine Crosby, where it came up during Kim's talk, and she was asking, have any researchers redrawn the curves to match approximations of cases with the discovered time 0 that occurred earlier than previously thought by scientists? I can't hear Kim.
So is Kim reacting to that one?
I'm hoping so. There you go.
I was talking, but I was muted.
Okay. Okay.
Sorry. So different models work in different ways. And the way that, at least the model that I've been building, the way that it works is I allow there to be some period of time over which we might have seen there might have been the first cases in North Carolina unseen to us, and I let there be a fair amount of freedom in the model for when that is, in fitting the model to what we're seeing in terms of diagnosed cases. Other models elsewhere, I think, have dealt with it differently. I just on Twitter this morning, I was seeing some results out of, I think, Northeastern that their model suggests an earlier start. I think all of the modelers we understand that certainly that infections arrived sooner than when we started seeing them, and I think most of the models incorporate that in some way, but the way that it's incorporated differs from model to model. I'm not sure if that answers the question, but I think, yeah, the way it's dealt with differs across models.
So yeah, so one model, or some models model it explicitly, like Kim is doing in her SC, JR, MD, QP, RST, whatever model. Others view it as a parameter that they can vary and look to see which fits the curve better based on different, more of like a Bayesian approach. They're all, they all recognize it and trying to address it in different ways.
Great, thank you. So the next question from Matt Kane was, if Kim was looking at asymptomatic individuals who could infect others through contact. In your slide, you had asymptomatic going straight to recovery.
Yes, so in that So the asymptomatic, people in the asymptomatic compartment are included in the force of infection equation. So they do contribute to the lambda that results in, or that represents the process of transmission. They do go straight to recovery in the model at present because diagnosis of asymptomatics is quite limited. So they don't, so they just, they recover, but they can certainly contribute to transmission, and that is included in the model. And before I'm gonna stop there, but I wanna give a shout out to Sarah Levanto, who is in UNC Epi and was a big contributor to the model. I mentioned Rachel Billick, but I forgot my acknowledgement slide, and I would be remiss not to note Sarah.
So Mark, you touched on this a little bit, but there was a question asking, I'm wondering if you were able to answer the questions from Republican legislators to the governor with your models. They seem like important questions to answer.
Yeah, so the questions were things like, so we basically bounded the two policies, one where we stay and where we are today, one is where we open things up, and internally we call that Mardi Gras party time, but basically remove everything, everyone goes back to restaurants and nightclubs, etc. Neither of those are probably likely to continue for the medium future. But it did give us a range of estimates. One of the questions was, can you do something sort of middle of the road? And that's what we're doing for tomorrow or Monday. Another one wants us to look at regional effects. And sort of because the Charlotte-Mecklenburg area is getting a major, is where the epicenter of this in North Carolina at least primarily is, but yeah, you have a cluster in Northampton County, for example. We did some early work with regional models, but haven't really come back to that. Certainly we know that the risk factors will vary regionally, and the degree to which you're elderly or have comorbidities, such as respiratory or cardiovascular, renal conditions, that varies tremendously across the state. And so that's on our backlog kind of idea, but the list of things to continue. So in terms of Dorothy's question, we're answering one of them either tomorrow or Monday, or at least, giving them an answer. And then, some of the other ones continue to be things that we're picking at.
Thanks. So another question came in from Hannah that says, the modified SEIR model you showed us is based on the true status of people, but our estimates are just that, with uncertainty due to sampling. But in this case, we have the massive uncertainty in measuring asymptomatic carriers. We don't know how many of those there are in general populations. Our first question is, how do we reflect the uncertainty of who is infectious in these equations? And our second question is, after this is over, whenever that is, we'll be able to get better data on how many people are infected. Can you use that in any way to alter the models for this particular pathogen?
I can take that one. Hi, Hannah. So it's a modified SEIR model. So initially, most of the models that were coming out in like January or February were SEIR models, because that was what worked well for SARS, the original SARS, where there was this period, this latent period where people really weren't infectious. But then we kind of started to realize with SARS-CoV-2 that there are asymptomatic people. We're starting to get estimates that it could be 20%, 40% of people. And that's mainly coming from like the Diamond Princess and some other places where they've really tried to quantify how many people are truly asymptomatic the whole time versus asymptomatic when you do a cross-sectional look at things. And I see more questions coming in. So we have that compartment, those compartments now where we are differentiating those things, but there is, as you say, massive uncertainty about how many people are in those compartments, how infectious they are. And I think one of your questions was about, as we get better data, can we use that information to alter the models? And the answer is absolutely yes. And we're keeping a very close eye on those estimates and how we can use those estimates to refine the models.
All right, well, we have reached the end of our time. So I just want to say thank you again so much to both Kim and Mark for participating in this. And also a reminder, if anyone else would be interested in presenting at one of these webinars, please email me. We'd love to have you. All right, thank you everyone so much.
Thank you.